Welcome to Hacking Hypermobility Podcast.
I'm Luna.
And I'm Shelly.
And we're two bendy mamas.
Hacking Hypermobility. Hey, welcome back, everybody, to the podcast. Thank you for joining us today. I'm confused. No, I'm not confused. I'm going to keep talking. I scrolled on the computer to a different page, and the page is in front of me. So we're just going to start over. No, we're not. I'm just going to keep talking. So welcome back, and thank you for joining us today. And as we've started talking about this journey into your medical evaluation for hypermobility disorders, including the Ehlers-Danlos syndromes and hypermobility spectrum disorders, EDS or HSD. So
if you didn't catch our last episode about the barriers to our care, we recommend you go back to episode 3 to get some helpful advice to help you prepare.
Yeah.
In this episode, we're going to go ahead and start talking about the presently used scoring tool for the initial portion of the evaluation of hypermobility. We're going to break down the first box labeled Criterion 1 on the HEDS diagnostic criteria. So just to be clear, though, the diagnostic pathway according to which type of connective tissue is suspected differs, and you could go down a different path depending on your particular presentation of your hypermobility. So HEDS, HSD, those are more common. The diagnostic pathway differs from that of the more rare types of connective tissue disorders and the more rare types of EDS. Diagnosis largely has its basis in the identification of a collection of symptoms, though.
Symptoms, right. And so symptomatic hypermobility can be due to many things, including specific heritable disorders of connective tissue like Ehlers-Danlos syndromes, Marfan syndrome, which we've talked about briefly, Stickler syndrome, which I think we're going to talk about later, osteogenesis imperfecta, and others, as well as joint shape, having looser ligaments or poor muscle tone, and that can be with or without a connective tissue disorder. There's also other conditions like Down syndrome, cerebral palsy. Please apologize. I am struggling with some weird GI issues as far as like talking and throat stuff. So my voice might I might have a little vocal fry, and also like I've been slurring and I'm not trying to. So if that comes up during this episode,
It's okay.
Just be aware of that. I have a barium swallowing test tomorrow.
So we're overthinking all of this stuff.
Yes, like I'm hyper focused on how well I'm speaking, and I'm not doing it very well. So anyway,
not very podcasty of us.
I'm not very podcasty today, but we need to get this episode out. So anyway, the other thing that can be symptomatic of hypermobility is if you have an injury or repeated stretching. And so yoga enthusiasts and gymnasts, things like that. And also, what now?
And now even COVID-19, long COVID, is associated with hypermobility syndromes and some of the comorbidities, including POTS.
POTS, yeah.
And mast cell now.
Oh, no, I didn't hear the mast cell part.
Yep.
Great.
So, long COVID friends, welcome. Now, for transparency, though, we are not medical providers. We're speaking from the experience both as patients. Also, there are other inherited connective tissue disorders. That's not a fully extensive list. So be persistent in working with an informed medical doctor on your own zebra journey, which is particular to the inherited, Ehlers-Danlos syndromes. But be mindful, there are other causes of these symptoms and hypermobility. And that is why it's so vital to work with a doctor to find a provider aware of the various presentations of the hypermobility disorders if it's affecting your health and you have multiple systemic issues.
All right. So, Luna, can you review our Hacking Hypermobility general steps to getting a diagnosis for everybody?
Yeah. So our big hack from the last episodes were, first, you need to document and organize your symptoms and history. Gather it all up together, get yourself organized. Number 2, find a provider. 3, get screened for hypermobility. 4, the clinical evaluation of generalized joint hypermobility. 5, the clinical evaluation of the criteria for hypermobile Ehlers-Danlos syndromes, which includes scoring of your hypermobility and an evaluation of the additional features in your history, as well as the exclusion of other diagnoses, because HEDS is a diagnosis of exclusion currently. And then finally, if warranted, genetic testing and consultation.
Okay. And so first you should be evaluated to determine the severity of your hypermobility. And so based on your clinical presentation and the history, which Luna just mentioned that you're going to document, your doctor will decide how to proceed. So how do you get evaluated?
So, once you've come to the conclusion that you may have some more issues going on and you want to approach this with your doctor, you bring up your concerns related to hypermobility and any other health issues. The first medical assessment will involve an assessment of hypermobility. Hopefully, your primary care provider is willing to do this initial evaluation with you. If not, depending on the specialist availability in your area, you may complete this evaluation with a type of specialist called either a rheumatologist or even a geneticist. I've even seen an orthopedist do this evaluation. However, most are surgically oriented, and also even other types of practitioners might do this and then refer you on. Some chiropractors have done the evaluation. Some physical medicine doctors have done the evaluation and refer patients onto. So it just kind of depends on what your own personal journey is and what health issues you've been dealing with or seeking help with, and what providers you've seen.
Yeah. And so we recommend that you familiarize yourself with what to expect, which is what we're doing right now. And so presently, the published HEDS criteria for diagnosis uses something called the Beighton score. And that's like the first step. And so that criteria are published on the EDS Society website, and we will link it in the show notes. And it was also part of your homework. Did you do your homework? I actually forgot we assigned homework because I
think it was kind of a joke.
But I know. But
kind of a serious joke. When we said, hey, get yourself organized, we said, hey, go look at this criteria. So if you did that, if you've got the HEDS criteria in front of you, this is the first box at the top of the page. It's labeled Criterion 1. It is for the evaluation of what they call generalized joint hypermobility. It's really just the assessment of, are you experiencing hypermobile joints? So this section of the evaluation begins with the measurement of the flexibility of just 9 joints that are scored. And then there are some additional screening questions about your history. So this 9-point scoring system is called the Beighton score, and it has different thresholds for 3 life stages that align with the progression of hypermobility disorders such as EDS. Since hypermobility disorders change over the course of a lifetime, these scores change as you age. HEDS patients typically show increasing symptoms as we approach adolescence, and then as our bodies experience wear and tear over a lifetime, change presentation again as we age. So the 3 life stages defined with decreasing thresholds for this score are first the prepubescent one. So before you go through puberty, the hormonal changes that bring on adolescence. The second stage is post-pubescent, so that's typically teenagers and then adulthood. And then finally, the third stage, the third scoring threshold, which is the lowest, is for people over the age of 50.
All right. Okay. So we're talking about the scoring system. How did they come up with the name Beighton, or is it Beighton? I always said Beighton. Am I saying it right?
So I actually looked this up because of
course you did.
According
That's why I didn't, because I knew you would.
So according to a tweet from Dr. Emma Reinhold, who is a UK general practitioner that spearheaded the previously referenced GP Toolkit project in the UK, who also, her Twitter is fantastic. According to Professor Rodney Graham, the godfather of hypermobility, who knew people, yes, people, more than one person, the Beightons, it's Beighton, like take a bite out of crime. It rhymes with Brighton, as in the old criteria for joint hypermobility syndrome.
So that's where it came from too, because I was like, the name, did they just like tweak the
Make
name?
It confusing? Like, why is it like this? Yeah.
Yeah. So it's actually, it's a people, and it's not like we're just going to be deliberately confused.
It is a person and their spouse. So it's funny though, they made the joke that having the scoring criteria 1 letter apart was the biggest mistake of their
Yeah.
career. So the old criteria, the Brighton criteria, is no longer used, but the Brighton score is still used.
So it's Brighton criteria, Brighton score.
Yeah. And so the Brighton score is someone's name. So it was born out of early research dating back to actually 1964 when modern hypermobility research started happening. So the Brighton score has its origins when Cedric Carter and John Wilkinson devised a scoring system investigating congenital hip dislocation in Great Britain. And that method was later expanded by a researcher named Peter Brighton.
Okay.
And a nursing sister named Greta Winch studying EDS in London in 1971. Together, the pair actually married, so they are the Brightons.
Okay.
And they studied the epidemiology of generalized joint hypermobility in the Kalahari semi-nomadic Bushmen and the Tswana population in South Africa.
Okay.
So Greta actually noticed that hypermobility could be different depending on right side, left side, expanded the score that was previously used, expanded it to the 9 points that we use today. And the story is she actually came up with this like around a campfire. When I tell you like they were doing research in the field with the Bushmen, yes, this criteria was like expanded around a campfire in South Africa. So the study results were then published in 1973. But by the way, fearing accusations of nepotism since they were a married couple, she was not credited as an author in that 1971 study. She has been recognized posthumously, however, though, which is nice. I appreciate that, especially as a woman in STEM. So it's important to note that the origin of the scoring system that we still use today was to identify hypermobility by scientists studying another culture than their own in a non-invasive way with some distinct language and cultural barriers and differences. So it was an epidemiological tool in the study of the epidemiology of bone and joint disorders. It's quite different from what we are talking about in terms of clinical application and assessing patients and diagnostic criteria. So now you might be wondering, okay, well, what's epidemiology? Well, I kind of just gave you, a description. So they're in the field, they're studying a different culture. That's not necessarily a requirement for study of epidemiology, but it's a branch of medicine that deals with the incidence, so how frequently something occurs, the distribution, how widely it occurs, and possible control of diseases and other factors relating to health. So it's a research-based health study practice, just trying to understand where a disorder, a disease comes from. Okay, so this epidemiological or research tool was later adopted to clinical practice.
Okay.
And by clinical practice, I mean how we manage patients, like to help manage their disorders, diseases. When you go to the doctor, that's what I mean by clinical practice. And so as a result, the Brighton score is a basic screening tool that identifies some visible and easily identified hypermobile joints, but not everything, right? In 2017, the International Ehlers-Danlos Syndrome Consortium published revised diagnostic criteria, and the name was modified slightly to this new diagnostic term we know as HEADS, which stands for hypermobile Ehlers-Danlos syndrome.
That's when they changed it from like EDS type 3, right?
Right.
And that's
that is the current terminology and the current criteria, the 2017 criteria. When I told you to do your homework and go to that worksheet, this is what we're referencing. So the first portion of that HEADS diagnostic checklist begins with identifying generalized joint hypermobility using this scoring method from the Brightons research, from the South African Bushmen around a campfire, trying to find a way to identify hypermobility in these tribes people that they had difficulties communicating with. So for the purposes of their work, though, the scale was well suited, being easy and quick to perform in large numbers of people. It was almost like conversational. We can assess these things without really, going into a physical exam room or anything. So it's not a full body assessment though, and it does not account for the very presentations of inherited connective tissue disorders that present with hypermobility. It has its limitations. That is why the first section of the HEADS criteria, there are some additional clarifying questions. So let's break down first this 9-point system known as the Beighton score and those clarifying questions.
Okay, so we're going to describe the scoring system, but we recommend a video to see the assessment, and we're going to put that in the show notes. And just so you know, a joint is where two or more bones meet in your body to allow movement. I know what you were thinking because I was mentioning joint. Okay, no, I'm talking about the ones in your body. There is a typical range of movement, and that flexibility is measured with an instrument called I should have looked this up, a goniometer. How do you say that, Luna? Goniometer? I didn't pre-practice that.
I've heard it called
goniometer.
Joniometer.
Joniometer.
I don't know.
So it's like the J, not the G. Okay, it's Goniometer.
Goniometer.
My guess is, though, you're not going to have one of those. Don't go buy one.
Don't. No. If you're going to buy anything, buy one of these. Okay. I recommend. We'll put that in the show notes too. Anyway, enough about that. Can anybody just do this? Can I just be like, hey, let me watch this video and you're going to assess me? What do you think?
Yeah. So no. I do recommend you watch the video to understand what we're looking at, and then you kind of get an idea of the checklist and what they will measure. But it's important that someone medically trained on measuring range of movement performs these measurements. So there are anatomical landmarks and medical techniques in positioning your body as you are measured to ensure accurate assessment. But in some of us, the flexibility is so pronounced.
Yeah.
You can see it even visually with an untrained eye. Still, we want you to be
like this.
Yeah.
See people? Yeah.
So she's showing you her backward elbows. And it's funny to me because I was literally
one is worse than the other.
Yeah.
You can see my left.
It's very obvious. Like when I was in 7th grade, I have a distinct memory of this guy across from me at a table being like, what is wrong with your elbows? Like, we have it broken. So when I say it's very pronounced sometimes, some of our joints are so obvious that people think like we're injured. Okay.
Yeah.
Still, we want you to be prepared for the exam and what to expect, because some joints are not as flexible as others. And you may want to point out, hey, I have these other issues, or I have an injury in this joint, etc. But we'll talk about that.
Yep. And so the Beighton score is tallied after measuring the knuckles of both little pinky fingers, the base of both thumbs, both elbows, both knees, and your spine. Toe.
Which there's only one of.
Only one spine. Thank God.
Yeah.
Causes enough problems.
Are we being really?
Seriously. Could you imagine
pretty intense spine
degenerative disc disease and you have 2 spines? Jesus. No, thank you.
As you listen to this episode or prepare for this medical evaluation, we recommend care with your joints. If you experience problems with hypermobility symptoms, and like the majority of us, you are now middle-aged, it's likely that they give you a little bit of trouble because, like we stated before, the average age of diagnosis is about 40 years old. So you're probably actually at that stage of progression now. You're past
above average.
We are both above average
I like it.
in so many ways. So if any of these joints are problematic or injured, you may not be able to assess it. Also, other joint disorders that are related to like autoimmune conditions are more common in hypermobile EDS patients. So you may have joint inflammation. If you have a day that the pain is not severe, I actually recommend you take a video of yourself, have someone else record it or set it up, so it's stable, recording those joint movements that they do in the measurement described in the Baton score to take with you to your medical exam in the event that you can't tolerate that same movement that day. So, for example, another thing that happens with us is you may have really tight muscles. I have the back of my thighs are constantly so tight that unless I've done a lot of stretching, I cannot touch the floor with my hands flat any longer. Although I can, it greatly varies for me in my ability to do it.
The muscles preclude you, not the joint.
My muscle difficulties as a result of my hypermobility now at this advanced age. Also, I have hip dysplasia, so I have severe hip pain. So some days I can't do that just because the pain is so severe.
Right.
So my point is, sometimes we wait a really long time for those appointments. If you've got a day where you're like, oh, I think I can, do this today, go ahead and put that in part of your preparation of materials for that evaluation appointment where they actually measure. But so let's actually talk about how they do that.
Yes. But before, you brought up a good point talking about taking a video. And that's why I don't remember what episode, but we were doing I mentioned symptom tracking, taking videos, and that's good for tracking your symptoms too and showing your movements. And also, like, I struggle with using words sometimes to describe actions or what I'm doing. So having that visual presentation to show this is what I'm talking about, because sometimes the words just don't flow. So but back to Baton. So the movements that you're going to have to do in the interest of our own joint health, even though we do like our party tricks, we are not going to demonstrate. And as we're going to do our best to describe these verbally, as I just mentioned, sometimes we struggle with that, but that's why it's written down for us. Thank you, Luna. Because if I had to I was about to say free ball. Not free ball. What is the word? Not beep. What? See, we're talking about words not coming
now.
Not free balling. What am I talking about? Riffing, like off the cuff. Ad-libbing.
Because I'm so distracted by free balling.
Ad-libbing. I'm talking about ad-libbing, not free balling. Anyway, if I had to ad-lib the descriptions, it would be very bad. Anyway, if you're watching the video version of this, first of all, do you like my shirt? Second of all, sorry, we're gonna just go. All right, so we're gonna put the pictures up while we're describing so you can see it. If you feel good and I'm not even gonna say it. Luna, what's the first thing we're gonna do? We're gonna start with pinkies.
Okay, so speaking of the hand of the queen, we're gonna start with the hands.
You have to be watching the video to get that.
Yeah, you have to hop on YouTube. Otherwise you won't get this show. So the first point in the scoring is your fifth finger, aka the pinkies. So with your forearms and the palm of your hands flat on a surface, try bending backward the littlest finger. Okay. So we're going to put the picture up and show you what the position is of your forearm and your hand and your wrist. So can your pinky fingers extend backward beyond 90 degrees? 90 degrees is a right angle, okay? Like the corner of a square, okay?
Yep.
If your pinky finger can bend backward, I want you to add a point for each pinky, right and left side.
Okay, now Luna, what is your score on this one? Do you have 2 out of 2?
I can do both. Okay. And it generally doesn't hurt me. We will see. I am having wrist pain today, so I don't have a surface, but I can go quite far.
Yeah, I'm 2 out of 2 too. I'm not going to do that. My hands are jacked up today. I'm not going to do that today. So we're both 2 out of 2 on that. Okay, so next is your thumbs. So with your arms outstretched and the palm of your hand facing downwards toward the floor, palm of your hand downward, can you pull your thumb backwards to touch the inside of your forearm? I cannot do that and never could. Those are the 2 points I don't have.
I don't know that I can show the camera, but I can very easily.
My niece can do this.
So what's odd though is my hand anatomy is a little different. One side of my thumbs, I will show the screen, I can like bend that joint completely backward.
Ow.
So on that joint, it's even weirder. But also my left hand, my wrist is really hurting today, so I'm not going to do that.
Okay. So if you can do that, if you can pull your thumb backwards to touch the underside of your forearm, you get 1 point for each thumb that can do that. So I'm 0 out of 2 on that. Luna, you're 2 out of 2?
2 out of 2.
Okay. All right. Next, Luna, elbows.
Okay.
I think we know what my score is on this one.
So your elbows are the joint in the middle of your arm, of course. This is your funny bone. It's your funny bone extra funny, basically. Okay. So with your arms outstretched, okay. Normally, I think most people's arms are pretty straight.
Yeah.
From shoulder to hands, right? We want you to put your arms outstretched and this is so hard to do, your palms upright, facing the sky, okay, or the ceiling. Does your elbow bend backward? Okay, like I don't know that I can really get it on the screen, but mine are very backwardsy.
You can see mine here.
And I've actually been doing PT in my elbows, or OT, excuse me, because I have ulnar nerve compression through my elbows because it's been so severe. Now, the good thing is it's really only my left side that hurts terribly. As I should have shown you with my right side. But I've been doing work on it, so maybe it's a little stronger. So yes, so we both get double points for that. I know Shelley showed us earlier her cray elbows. So.
My cray elbows. All right. So now we're going to do knees.
So now you got to stand up. So we're not going to demonstrate this.
I'm not going to stand up. Stand up and lock your knees. And if you don't know what lock your knees is, it means extending the knees backwards as far as they will. So like, not where I actually generally stand without my knees locked, because if they're locked, it hurts, because
I have to think very hard about, hey, soft knees, soft knees.
Yep. Because when you lock your knees, if the angle of your knee extends greater than 10 degrees, like your elbows, that's kind of this, think about it that way when you're that's how I had to visualize it. Cause I didn't realize for a long time my knees did this too, just because of the way I viewed them. And then no, my knees do that too. So if your knees do that, 1 point for each knee. So I'm 2 out of 2 on that, Luna.
So funny story. I thought that mine were that they were not going to meet the criteria, but when it was measured, they did. And I've actually had some knee problems. Anyhow, even having had, seeing other people have more severe hypermobility, my daughter's knees go much further than mine. Even having some knowledge of that, I was like, oh, my knees aren't going to be. No, they were. They were like 15 degrees. So, but also, I am a chubby zebra, is my hashtag I created. I have pretty pronounced lipedema. So
that's common.
What that means is I have extra fat deposits in my lower body, particularly and in my appendages. So you can see it. I will show you. I have extra fat deposits in my upper arms, like see I have skinny arms, skinny face, but I have some oddly proportional fat deposits in my rear end and my legs. We'll talk about that in another episode, but my point in saying this is that can kind of hide some of the angles, because the fat deposits are distributed differently than in typical anatomy. So I have fat deposits in a columnar shape around my leg. So it hides the angle. And also, like, I have fat deposits where you wouldn't, like I have fat deposits in my knee more than typical anatomy.
So is that why some people assume a person with a larger body can't be hypermobile, because they can't see it as, like, my elbows, it's really obvious, and you can see it more visually than someone who would be larger. So
my elbows are very obvious regardless of the
yours are, but I'm just saying, like,
but I will say in my legs, I don't see it as much because it does mask the angle, but also because the fat deposits are much more pronounced in the lower body in lipedema. That's kind of a classic presentation, but it is interesting that the fat deposits are the same throughout the whole, like, not the same, but it's the typical presentation is it's known as columnar, meaning there's a fat deposit around it's the whole entirety of the leg. So it doesn't look like what we expect normal anatomy to look like. So it does hide, it masks the shape of your muscle in your leg.
That makes sense. That tracks.
Also, what's interesting is because of my view of my body before I understood what lipedema was, I worked very hard to try to get rid of the fat and be healthy. And I did a lot of strength training, and I have amazing legs and glutes. I have a lot of strength. And that also, my giant quads also mask the hypermobility because it's so stabilizing, which is a good thing. But also, if I do just relax my muscles, there it goes.
Our bodies are so weird.
They
Okay,
are.
so
But also, lipedema is very comorbid in Ehlers-Danlos. There is medical research on it. So if you are a person that you think, well, I have a larger body, so this doesn't apply to me, and I've been told this only happens in skinny people, they're wrong. That is a misconception. It is inaccurate. I was technically obese at one point in my life. I was hypermobile then, just as I am now.
yep.
And in fact, I would say it contributed to my weight issues because one, lipedema made me mess with my head and I just gave up on taking care of my body. But also the lack of ability to maintain physical exercise, the depression, the neurodivergencies. I could go on and on, but
All connected. Okay, so we did pinkies, thumbs, elbows, knees. We got one more place. What's that? That's the
okay,
spine.
your spine. So you're back.
Okay.
So the last portion measures the flexibility, not fully, but in one way, it measures the flexibility of your back and trunk. So we'll only have 1 point since this is not obviously a right and a left side thing. So still standing, you will bend forward, and without bending your knees, can
Your
you touch
hypermobile
the
knees.
floor? Here's the floor. Can you touch the floor with your hands flat on the floor? Okay.
I have a question.
Mhm.
And okay, I have not taken a single anatomy class ever. I'm just trying to think. If
And I have
you,
extensively, so go
yes,
ahead.
yeah, yeah. If you are bending forward with and you're hypermobile with your knees locked, so your knees are gonna hyperextend.
Mhm.
Doesn't that jack up measuring your spine?
Sort of, yes. And that's kind of the point. So if your knees hyperextend,
Well, I feel like you're an automatic on the floor.
likely, unless you have really long limbs, if your knees hyperextend, that means your knees are going backwards, which means your legs are curving. So then you are closer to the ground.
Right. So could you get a false positive on your spine because your knees are so hypermobile?
Possibly.
I don't know. I'm just thinking
But so,
like,
I mean, really, this is measuring just one movement of the spine.
well, right. That's why I'm
Also,
like, why are they
um,
basing so
there's
much
many
on this
other
one thing that
indicators.
could be skewed by your knees? Like that
Yeah.
just seems to me, but I
So
mean, I
my
know we're
mom
going to
can't
talk
do
about,
this, and I don't think she ever could.
but her knees
And
go.
no, her knees
Okay.
aren't. She's
I,
very
I
hypermobile in her neck, and
bobblehead.
actually has had 2 surgeries. But so my point is, her spine hypermobility is kind of you couldn't have
Different.
tested it this way. So what is also not tested in this and precludes me from doing this most of the time is my severe pelvic and hip hypermobility. I have what's called hip dysplasia, meaning my hips come out of the ball and socket joint.
That doesn't feel good.
I mean, that is one of the most severe presentations of hypermobility.
My
And
sister was
it
born with her
precludes
hip
me
out.
from doing this.
Yeah. My sister was
Can you
born
do
with her hip out of joint. Like they put it in and then she wore a brace for like the first 9 months of her life.
Yeah.
Damn. So you get 1 point if you can do that.
Mhm.
Okay. So now let's, if you're playing along at home, let's add up your points. Out of 9 possible points, what was your total, Luna?
If I would do this today, I could not do the spine.
Okay.
So I would get 8.
Okay. And my score is 7.
And when I was tested, I could do the spine.
Okay.
But it was very painful for me.
Yeah.
By the way, I did not learn that I had hip mobility until afterwards. If I had or hip dysplasia,
Yeah.
if I had known, I would not have done it then because I still would have obviously, had a high score.
Yeah.
I won't do this for fun at all anymore because it causes I have such instability in my pelvis and I'm constantly fighting my hips that I won't even try to do that. So the total score can indicate hypermobility depending on your life stages we discussed. So 2 key questions pertinent to now determining your score meaning are 1, have you experienced puberty? And 2, how old are you?
Okay.
So Shelly and I both fall into the second category. We've both experienced puberty, but we are both under 50.
Yep. So a few
So
more years. The point thresholds for the Beighton scores indicating hypermobility are, all right, for people who have experienced puberty and are under the age of 50, like us, you have to have a score greater than 5, greater than or equal to 5. Mine is 7. Luna's is 9. I skipped over the children.
no,
Bear
mine's
with
8.
me.
If I were to test today, I'm 8. But
That's
when
right,
I
you're
was
8.
when I was diagnosed, I was 9. Yeah.
Okay. For prepubescent children, a score of greater than or equal to 6 is a positive score. And if you are older than 50, a score of greater than or equal to 4 is a positive Beighton score.
So my daughter's score was also 8.
Okay.
She can almost touch the 4, but not fully. And she was she's
on the
starting
cusp.
puberty. Yeah. So they were like,
Yeah.
but still it was much greater than, it was greater than 6. She was an 8. But also, they may even say for a prepubescent child, we're not going to worry about it too much.
Right,
Literally.
because let's see what happens
Let's see what
with
happens.
puberty.
Yeah. But they're going to follow that. Yeah.
The weight, I have issues with the wait and see. But anyway.
Yeah. So if your score is just 1 point off from the score given from your group,
Okay.
like the one below, then you would proceed to the clarifying questions in the next half of the HEADS Criterion 1 box.
Okay.
So this is known as the 5-part questionnaire for hypermobility.
Okay. So we're done with the physical scoring part. Now, on the HEADS diagnostic checklist, the next step, Criterion 1, has a bunch of questions, and they're going to ask, what are these questions about? This is why you need to know about your family history, or is this your history?
This is a particular questionnaire that came from a research study on hypermobility by Hakim and Graham. We mentioned this as a helpful screening tool in a previous episode. It is and has been identified as a reliable screening tool and predictor. In and of itself, it's a reliable screening tool just to conversationally ask these questions. So it was added to the diagnostic criteria. It is also now used to expand on the limitations of the Beighton score. So let's review the questions for you. So Shelly,
Yes.
first question, I'm going to ask you them, okay? Can you know, or could you have ever placed your hands flat on the floor without bending your knees?
Yes.
Okay, so you see how it's addressing that limitation of the Beighton score. When I said I can't do that now, it's, yeah.
Okay.
Can you now, or could you ever bend your thumb to touch your forearm?
No.
Okay. And as a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits?
100%.
100%, yeah. As a child or teenager, did your kneecap or shoulder dislocate on more than one occasion?
Yep. I put it back in myself.
Yeah, my dad taught me how. Do you consider yourself, quote, double jointed?
Yes. And I hope we talked about how double jointed isn't a thing.
Yeah. So that's not a term, but it is colloquially
It's not a
commonly
term,
used.
but it's a term.
If you've been called double jointed, you probably have hypermobility.
Yeah.
But so those questions are those questions that came out of that research from those hypermobility researchers that are all about your history prior to now. So you see how it kind of addresses the limitations of progression.
So how many of those do I have to say yes to?
So answering yes to 2 or more of those questions, those 5,
Okay.
suggests hypermobility. So if you have a positive Beighton score, as we defined, that's subclinical, just one below that threshold, and then you also now have 2 or more of these questions that you answer positively, then you meet the criterion for box 1 on the HEADS checklist, and then your doctor would proceed to criterion 2.
Okay.
And which is a much more detailed assessment of your physical signs beyond just the joints, as well as your personal and family medical history. So we'll discuss that in the next episode in greater detail. But first, we're just going to stay on this topic with just the Criterion 1 and discuss the concerns from the community of patients, researchers, and practitioners that have been using this scoring system.